All right, I think we're ready to roll.
Then whenever the scribe is ready and the whiteboard is up, I'll start with the chief complaint. Okay, yep, there it is. The chief complaint, we have a 58-year-old gentleman, and he presents with a 5-month history of coughing fits with scanty expectoration. So a little bit of phlegm is coming up, and it's been going on for 5 months.
Okay, we have a chief symptom of cough, and we've already gotten a specification that it is not completely dry, that there's some expectoration. And to me, just the difference between a dry cough and a productive cough, although I guess the qualification that Hans mentioned of scant, I guess makes me want to bridge both worlds in my mind. You know, every healthy airway creates some degree of mucus. That's just part of normal kind of clearance function of coughing. So this could still be a sort of a true problem of a dry cough, potentially with a normal amount of mucus coming up, you know, making us think about possible bronchospasm, possible reactive airway disease, or a post nasal drip cough, a reflux mediated cough, and potentially medication induced cough. But we could also be in a world of an actual abnormal airway process, sort of a secretory process or a parenchymal process, whether infectious, immune-mediated, malignant, or otherwise, with kind of an abnormal amount of bronchorrhea, production of mucus, that is also triggering the cough, and asking the cough to actually bring up that mucus and expel that mucus. So this is just one of the many examples I feel where you can't hold on too strongly to your initial kind of framing, initial problem representation of whether the cough is, you know, dry or productive, where you kind of have to be open to shifting or open to considering both initial possibilities. And then the other thing I'll mention is just the time course. Obviously, is really key to thinking about any problem. In this case, we're very much in the chronic phase where, you know, if the most common causes of cough or bronchitis are almost automatically excluded by that time course. This isn't, you know, a viral illness. This isn't a pyogenic bacterial illness. If it's infectious, it's kind of more atypical, and it's more likely to be non-infectious because of that time course. So I'll pause there. I'll just mention one more kind of possibility that the cough may not be necessarily a lung problem at all. That's where our mind goes, of course, but you know, cough can also be mediated by cardiac disease and kind of a degree of pulmonary edema that is being expectorated. It could be mediated by thoracic disease, kind of irritating the pleura and triggering the cough. Or it could be a neurologic disorder of microaspiration and increased cough because of that, or other kind of pathologic crossing of neurologic wires leading to cough when there's nothing to cough up at all. So with that in mind, I'm ready to kind of hear more of the story. But if I missed anything very helpful, just in terms of approach to cough not otherwise specified, Steph, please fill in, and anybody please unmute and help out as well.
I just saw some great thoughts about kind of both the patient factors, for example, smoker or not, and then what other symptoms does the cough keep as its company? So we'll learn more and get more from Hans first.
Yes, for the history of present illness, the cough has been going on for 5 years. It is annoying. He's coughing up a scant amount of mucus, as mentioned before. And the patient also admits that he or denies he has never experienced any shortness of breath, but he has to admit, I don't do a lot of physical exercise anyway. He tried several over-the-counter cough suppressants, and they do a little bit of a job, but not very much. What he really noticed during those 5 months, that he has been getting a cold more often. Even in the summer, when he never gets a cold, he has 2 or 3 colds that seem to be very annoying to him. He also noticed that when he's driving in his car and he has to focus, or when he's reading or watching TV, his eyes start to burn. And he was thinking about buying natural teardrops. In the ROS, review assistance, the patient denies any fever. He has not noticed any weight loss. On the contrary, he thinks he's a little bit obese. No shortness of breath, as mentioned before. And otherwise, he seems to be healthy. If you wish, I can continue with past medical history and family history, or we stop here.
Maybe let's stop here because I think you've given us some interesting additional information. So, and just to clarify, Hans, is it 5 years or 5 months of this
No,
cough?
I have my apologies. It's 5 months.
5 months. Okay. So, still qualifies as a chronic cough. We had a nice discussion of sort of what is sputum production or not help us in terms of narrowing down the anatomic location. But here I'll just sort of layer on discussion of what company this cough is and is not keeping. I will say I am relieved that it doesn't have some of the symptoms of just systemic inflammation with weight loss or fever that would immediately make us prioritize malignant etiologies as well as more kind of indolent infection etiologies. And the fact that it's not associated with dyspnea makes me think perhaps the lung parenchyma or the pleural area is not involved. I'm not reassured enough that we wouldn't, of course, get chest imaging to actually look at the lung parenchyma, but interesting that at least the symptomatology seems to be kind of airway mediated. And Zaven nicely outlined, right? Cough can be triggered anywhere from the upper airway down into the bronchioles. So I still think the pathology may be there. What company this cough does have is these more frequent upper respiratory symptoms. I'm being careful, I'm saying upper respiratory symptoms instead of upper respiratory infection, because I think we need to maybe at first think about a potential differential diagnosis for if he's having sort of runny nose and sore throat. Sure, it could be getting viral infections at atypical times and increased frequency compared to usual. If that were the case, we'd certainly want to think about any new exposures he had in terms of contact with other people. And we'd also need to think about, is there anything about him as a host that's making him more predisposed to infection than before? But I want to pause a minute and I'll happy to have people help me in the chat. What else could cause symptoms that might seem like a cold that aren't? Certainly allergic rhinus and mediated symptoms could be it. So is it allergy related? Is there other non-infectious inflammation of the upper airway in general? And pharyngitis, rhinitis that actually aren't, again, being driven by infection, whether it's allergic or otherwise immune mediated, I think will be an important category to think about. And then the burning in the eyes is really important sort of second symptom to think about also. I'll say listening to that symptom on history is going to prime us even more into an eye exam than we might have done otherwise when doing a physical exam, right? When someone comes into clinic with cough, you don't necessarily, right, take a good look at their eyes. So the burning sensation in with his eyes, I think can be very broad, right? Could be that the eyes are dry and that he's right, he does need some sort of artificial tears. Doesn't mean there's actual itis also of the layers of the eye. Is he having scleritis or conjunctivitis? Are we actually seeing multiple mucosal surfaces, including the surface of the eye, being inflamed by whatever this process is? Is it at all related to the same process, whether viral or not, that's driving kind of his upper respiratory symptoms also? So I think as we segue into the next section, I'll let Zaven add anything else in, but I'll say we now have a middle-aged gentleman with a chronic cough associated with upper respiratory symptoms and kind of eye inflammation as well. Again, being very careful not to overcode that into infection right now, although that's what he's kind of worried about. And I think there's sort of a broad variety of potential differential diagnoses for that, but thinking of those multiple affected mucosal surfaces, I'll say early on, thinking about sort of immune-mediated disease, I think will be important as we learn more.
I think my mind kind of went in a similar direction of just broadening the kind of mental representation of the problem. You know, again, time course is so important, right? Like if there was an acute onset of chest, upper respiratory, and eye symptoms that you know, viral infections, allergies, very, very common, obviously, and constitute a huge chunk. In the chronic time course too, you know, you can potentially develop an allergy to something that would affect all of those mucous surfaces, and environmental allergen, I mean, of some kind. But there's also yeah, in this chronicity, and some folks, Sri and others in the chat are mentioning you can have autoimmune disorders that also have kind of affect all of those mucosa. And the dryness specifically of the eyes is interesting. I don't know how much, Hans, you meant to emphasize sort of like wanting to get artificial tears, but it made me think, Steph, when a couple of years ago we went to Utah with our kids in the winter to ski from Houston, which is a very humid climate, to a place that was cold and dry. And you know, within a couple of days, all of our whole families and our kids' lips were chapped and bleeding, cheeks were red and cracked, eyes were dry and irritated, and most prominently and symptomatically, we couldn't stop coughing. I think that same dryness of the eyes that is very irritating also happens when you inhale that dry air, and your mucous surfaces in the airways also dry out and get injured. And part of the response to that and the healing is the blunt instrument of coughing. So I think if the driving process here could be inflammation, right? But it could also just be sort of xerosis, severe dryness of all of the mucosa that are involved here, and make us think, of course, about a specific autoimmune disease that tends to do that.
Well, here's some more, Hans.
Yes, then I'll continue with the past medical history, which for this gentleman is completely unremarkable, except for hypertension, and the medication he's taking is an ACE inhibitor, ramipril 5 milligrams, and hydrochlorothiazide 12.5 milligram daily. Other than that, he is completely fine. The family history is unremarkable. In his social history, the patient mentions he's married, he has one child, he works in an office, so he's not particularly physically active. He never smoked, he's been a lifetime non-smoker. He does not use recreational drugs, and he consumes a glass of wine occasionally. And I think I might continue with a physical exam, and then we have something to discuss again.
Thank you.
Now, on the physical exam, the vitals, let's just wait until our scribe jumps up to the vitals. We have a heart rate of 80, a blood pressure of 136/85, a respiration rate of 20, and a saturation at room air of 93. The general, he's well appearing, he's not in any distress, slightly obese. We had a look at his eyes, and conjunctival hyperemia was noticeable in both eyes. The skin showed no rashes, extremities, and no edema. The lung, however, there were fine crackles and rhonchi in subaxillary and infrascapular regions bilaterally. The heart exam was unremarkable. And I think at this point, I'll stop.
The ACE inhibitor appropriately caught a lot of people's attentions, but I think, and Hans totally would do us like that. But I think this is where, keeping the whole syndrome in mind is important, because the increased bradykinin levels that are caused by ACE inhibitors can enhance the cough reflex, but shouldn't affect the eyes or other places where this patient is having symptoms. And the other way I kind of think about whether something is signal or noise is how common is such noise, right? So a very significant minority of 58-year-old men take an ACE inhibitor. So it's not that big of a coincidence to say, yes, this person's on an ACE and it has nothing to do with anything. Whereas if it was, amiodarone and someone was having an unexplained lung syndrome, it would be much more likely that those things are related, because, again, amiodarone is a less common happenstance than an ACE inhibitor on your med list. So yeah, with that, I guess I'll just kind of turn to the exam and say that we have a signal for actual parenchymal abnormality in the lungs, and now we really need to sort of zoom in on that as a potential more specific finding to follow and reframe our problem representation with. And crackles are not specific in terms of etiology, but in a middle-aged sort of healthy ambulatory person are also very likely to be related to the sort of symptomatic pathology we were thinking about. So there's a bilateral process, it's a chronic process. We do need to define it better with imaging. It's possible that radiographically we might get further along, but I think it's even more likely that the radiographic findings will just won't narrow the differential of
They'll need
things we've already thought
clinical
about
correlation, you think?
They'll need clinical correlation and laboratory correlation and microbiologic and immunologic correlation within the laboratories. Just one fun fact about crackles when you're thinking about sort of immune-mediated disorders. They're variably sensitive. So in some interstitial lung processes, for example, they're extremely sensitive. So in idiopathic pulmonary fibrosis, 100% of people have crackles, and the onset of crackles is actually often precedes any radiographic changes, even on chest CT. By contrast, in sarcoidosis, which is also kind of brought up in the chat as a appropriate differential to consider, crackles are much less common even at advanced fibrotic stages. Yeah, Steph, what other thoughts do you have so far?
I guess I'll just add the sort of connection with the eyes, with the lungs. There's been some discussion in the chat about, can the cough itself cause eye problems? And probably the biggest link directly that I can think of is if people get subconjunctival hemorrhage from just the valsalva of coughing. And that, for example, in kids who have pertussis or whooping cough, is a common associated finding, actually, is having ecchymoses both around the eyes and in the eyes. So the force of the cough itself actually could cause that pathology. But should it cause general inflammation of the mucosal surface? I don't think so. And I think that, again, speaks to more of a unifying kind of systemic inflammatory signal. And again, I think right now it's probably most compelling for immune mediated, but we'll kind of see as we get the imaging in the labs.
You know how there's a sort of an entity that people think of as pulmonary renal syndromes?
Yeah.
Stuff?
Mhm.
Do you have any pulmonary ocular syndromes in mind?
Pulmonary ocular syndromes. I think just as people were already alluding to, sort of Sjogren's, certain connective tissue diseases, probably ANCA vasculitides would be the most common pulmonary ocular syndromes I can think of.
Yeah, and it helps to also just define the ocular syndrome better,
Yeah.
right? So if it's uveitis, which this very much could be, right? Sort of irritation, redness, then there's sort of an association with any kind of granulomatous process, right? So sarcoid, ANCA-associated disease, mycobacterial infections, can all kind of cause that immunologic side effect, I guess, that affects the eyes. So definitely want to know what the lungs look like, as well as some basic labs. But Hans, take us wherever you want. Yeah, Hans, you're muted. Do you mind starting over? Sorry.
My apologies, I didn't unmute. So the laboratory, the CBC is unremarkable. We have a normal WBC of 6,000, hemoglobin 14, and platelet 200,000. Chemistry is basically unremarkable. Sodium 141, potassium 4.0, glucose 110, calcium, magnesium, and phosphate was also measured and within normal limits. His bicarb was 24.4 and lactate 1.3. Because of his breathing difficulties, he was walked and an arterial blood gas was drawn. And the ABG showed a pH of 7.49, a partial O2 pressure of 32 millimeter of mercury. And then we have a partial CO2 of 32. And we have an alveolar to arterial difference of 53.73, which is actually too high and unnormal. Shall I continue with the second set of labs? We did a serology as well, and a CRP of 37 milligrams per deciliter was found. It was elevated. An ESR, which was 37, elevated. Then in this context, an anti-double-stranded DNA of 0.70, which is normal. An anti-SSA rho IgG, which is 0.30, which is again normal. An anti-SSB LA IgG 0.38, again normal. An anti-CCP, which is 6.5, that was normal as well. An anti-SCL of 70, which is again normal. An alpha antitrypsin was done, which is 257, which is slightly elevated, but I think this can be considered normal as well. And then chlorides in sweat, which was 50 millimole per liter, which is within normal range. And IgG, IgE, IgM, IgA, and IgD, all of them are within normal range. And I will stop here before I go to image.
Hans, could you clarify one thing? So pH 7.49, CO2 32, which kind of makes sense. But the arterial O2 pressure, could you repeat that again?
Yep. That one was a little bit low at 32.
Okay.
It should be around 18, I think, if I'm correct.
Yeah.
It was really low.
Yeah. I wonder if if you guys ever have a chance to ultrasound someone's radial artery, what you'll often see is the Mickey Mouse sign,
Mhm.
which is the artery in the middle, and there's actually, most people have two pretty prominent radial veins that run to either side of it. And it's easy to appreciate when you see that how often what we think is an ABG could actually turn out to be an accidental VBG, which could explain the low partial pressure of oxygen. I mean, this patient could also be hypoxemic, but if that ABG was done at the same time as the vitals, an arterial O2 sat or an arterial O2 partial pressure of 32 should correspond to, very low saturation of hemoglobin. But I think regardless, it's helpful to see that the patient is, I guess, if anything, hyperventilating. Yeah.
Mm-hmm. Yeah, and that's sort of the data that we have here with normal cell counts, normal chemistries, the ABG showing an alkalemia, which is being driven by the respiratory process, and might speak to the respiratory rate. Perhaps it is a little higher than 20 as it was measured at, but the patient has a primary respiratory alkalosis in addition to this hypoxemia that Hans has outlined for us. Otherwise, the rest of the broad serology, including all of these autoantibodies, really is unremarkable. We have an elevated CRP, which speaks to inflammation, but neither an ANA or many of the subserologies sort of point us in the direction of connective tissue disease. Where does that leave us for what we think is a chronic parenchymal process with a chronic eye process also? I think a lot of things we were already thinking about are still on the list, including some of the idiopathic interstitial pneumonia, some of the ILDs that can develop over time. I think ankylosing could still be on the list here. We haven't had those yet, and could be a way to actually get inflammation, particularly granulomatous inflammation in the lungs with inflammation in the eyes as well. Sarcoid is sort of seronegative, right? It requires tissue pathology to get the diagnosis. So even with a really thoughtful broad workup being negative, quite a number of things on our original list that was going through the chat are still on the differential. So I think sort of priorities will be imaging, particularly chest CT, and if we're able to get a high resolution chest CT, some of the idiopathic interstitial pneumonias, the diagnosis can be made by radiographic findings alone. And then the question will be otherwise, are there other abnormalities? Are there sites for tissue biopsy that are going to be helpful to get to the final diagnosis? And is there a list of other serologies that we haven't gotten that'll be helpful also? As I mentioned, sort of ANCA being an important one. Other thoughts you have?
Do you want off though to see the patient and better define it?
I think so, because it's kind of what, just as Zaven was saying before, what is actually inflamed? Is it just conjunctivitis or is it scleritis? Is it uveitis? Sort of knowing the depth of the layer of the eye will be very important to help us frame it more.
Is it anterior or posterior? But also just therapeutically, like no matter what, there might be treatments, topical treatments potentially of the eye process that could give the patient relief pretty quickly. So yeah, we have often ophthalmologists who are available to come see the patient in the hospital, or we just send them down to the clinic, and it's always so helpful. Real quick, guys, if you appreciated the hand-drawn circles, you might appreciate this, and Steph, maybe you can help out. So here's a butterfly ultrasound machine. Here's my wrist, okay? And I'm putting it right here over my radial artery. And put it, oh yeah, press the, oh, right, 1 sec, sorry. I should have, there you go, okay. Okay, here you go. Do you want to hold it up for a sec? And does it zoom in anymore?
Yeah, like that. Nope, you lost it. There it is. There it is.
Okay.
Can you guys see it's the vessel with the two smaller vessels on the sides? It's Mickey Mouse with his ears directly on the side as opposed to the top of its head.
And I'm squishing the ears a little bit.
Yep. So it's that sort of three bubbles there. All right, Hans, give us some more.
Yes. The next stage was imaging because of his lung disease and the chest X-ray. I actually have a picture, but I can give the official reading, which was very short and brief. The chest X-ray showed opacities involving the lung interstitium. And this finding has given rise right away for a CT, a high resolution CT, and there was presence of bronchiectasis with centrilobar nodules and areas illustrating the tree and bud pattern. And I think I might stop here and continue then with the pulmonary function test.
As I feared, yeah, I think we've confirmed a process in the lungs that is evolving the bronchioles, sort of an inflammatory process of the small airways, of the large airways as well, with the bronchiectasis. And I didn't hear about any ground glass opacities or consolidations, but
Sort of tree and bud,
yeah,
ventrilobular.
right. But I think the differential of all of the immunologic things and mycobacterial disease potentially, I forget actually if the pattern of nodules in sarcoidosis is different, but it's still, I think everything is still on the table within the differential that we were considering. So I think in a pulmonary function test, if we have them, great, but I also don't know, whether they show obstruction, restriction, or a combination of the two. I don't know if we'll sort of be any farther in the etiologic process. So I think I would really want high quality kind of induced sputum analysis, as well as some of the other blood serologic things that we were hoping to get, that Steph mentioned, specifically the Inca titers. Yeah. By the way, Steph, I don't know if you know this or if anybody does, and if not, please could somebody look it up. I guess as Hans, the treating clinicians, I guess, thought about cystic fibrosis at some
Early,
point. Yeah. And I realized this is a knowledge gap. Are there also these chloride channels in like involved in tear production, whereby you could have potentially kind of gland and mucus symptoms there too in the eyes, or would that have to be an unrelated kind of process? Does anybody know?
I didn't think though those chloride channels were in the eye in particular, but someone can fact check us.
Right, because they're in airway mucus secretion, the pancreas, right? Like the gut, of course, the skin, like where else are they? And would you have, potentially those symptoms? Ooh, Andrew, can you say more? So cystic fibrosis, I guess you get malabsorption of fat soluble vitamins potentially, and then vitamin A deficiency can cause certainly
Visual symptoms.
Yeah.
Interesting.
Thanks, Andrew. Anything else?
No.
All right, Hans, where did we go from here?
Yes, there are two more tests that were done, and actually a third one, which revealed the diagnosis. So the pulmonary function test, as mentioned by Zaven, it showed severe restriction without reversibility with an FEV1 of 42 and an FEV1 divided by a forced vital capacity of 78. So restrictive finding. On the basis of these findings, a bronchoscopy was conducted, and the bronchoscopy showed edema of the bronchial mucosa. It showed neutrophil infiltration, that was the biopsy of the sputum. Then it was tested for all kinds of infections, first and foremost for acid fast, which was negative. Culture was negative, and the serology of the bronchial lavage was basically repeated, and it was as before within normal limit. And at this point, I would ask everybody in the audience, what would be the next test that you will look at to come closer to a diagnosis?
So on bronchoscopy, it's really yeah, we're really seeing sort of a primary airway problem, really in the bronchi specifically with the edematous sort of boggy mucosa, which again could, right, be the explanation for having sort of the little tiny kind of nodules with interstitial markings, the tree and bud opacity. So we're left with sort of a, bronchiectasis and inflammatory bronchitis picture with, again, some eye inflammation also in this older gentleman.
Do you why don't we take like a 2 minutes and just as prompted by Hans, just kind of individually think about kind of what maybe our top three leading diagnostic hypotheses and what next steps we would want to pursue for those, and taking into account if folks haven't seen all the kind of comments in the chat. But I love just a mention of, we have some tests that are testing for some things we were considering. And Lucas mentioned, and I think some others, just the great concept of like tests aren't perfect. And so just because you have a negative test doesn't usually mean you've completely ruled out that the condition that you were testing with that test. So with that keeping in mind, just 1 or 2 minutes, I guess, come up with each of our best guesses here and next steps. And Steph and I have the benefit of chatting with each other. We won't do breakout rooms or anything, but let the internet be and ChatGPT be your breakout room buddy. All right, everybody. What do people think? And the micro was negative on all this view, right? Hans, just to clarify, we did a bronchoscopy, and the neutrophils that you were describing were just from the BAL fluid. We didn't take a transbronchial biopsy of a lymph node or the lung parenchyma or anything.
Exactly. It was only from the mucus.
Yeah. And the next aliquot, Hans is going to reveal the diagnosis.
Yes.
Yeah.
Or at least it will get us so close to the diagnosis that it falls from heaven.
Yeah. So what were people's kind of top three best guesses at this point, given what we have? Please feel free to unmute or type in the chat. We'd love to get as many opinions as possible here. I do think, Lucas, though, that whatever it is, it's very likely to be steroid responsive.
Throw some steroids at it and it's all going to get better, which is probably true.
Yeah.
Yeah, love seeing some of the thoughts come in. I can sort of say where my thinking is now based on what we have. I'm torn between ongoing kind of granulomatous process that's particularly affecting the airways, which could still be TB, even with the negative BAL. That could explain the eye symptoms also. And then, so if it's not sort of granulomatous inflammation, I do think hypersensitivity also could be a unifying way to explain both kind of the eye inflammation as well as the lungs. So that's sort of where I'm headed at this point.
Yeah, I'm there too. And then ANCA-associated disease, I think, is towards the top for me as well. To the point earlier of people still thinking about Sjogren's, the antibodies not being sensitive. I think repeating them could have value. And the other thing I might have missed, but if was there an ANA, Hans, that we did, or just the specifics? And
I think
the ANA
it was.
even was negative?
Didn't you say ANA was negative, Hans?
No, they didn't do an ANA, but
Okay.
even if it was positive or negative, I think it has no effect.
Yeah.
Yeah. All right. Yeah, I think sarcoidosis, and Marie, that's right. I'm kind of in the same space that, most patients with sarcoidosis will have lymphadenopathy, although there's kind of the stages, right? And I think it's stage 3 sarcoid where it's just lung interstitial and potentially parenchymal disease without lymphadenopathy. So it's there, and I think for that diagnosis, we'd really want to have ruled out alternate diagnoses, serologically, microbiologically, et cetera, and then really would love to have a biopsy of something kind of showing the typical features. But all right, Hans.
So we'll see if, I guess, based on our differential diagnosis, could the answer be in an ANCA serology? Could the answer be on a endobronchial tissue sample showing granulomas, or do we have a hypersensitivity panel or just exposure in the history that could speak to that? We'll see.
And the other thing that I have to look up every time, but again, the ophtho exam of whether there's like anterior versus posterior versus panuveitis, I feel like that breakdown sometimes is differentiating among potential sort of the systemic autoimmune diseases that can be associated with it. So that could be another clue to kind of alter probabilities.
All right, Hans, over to you.
Okay. So the test, or the next test, was actually suggested by the mention of dry eyes and the finding of conjunctival hyperemia. So it was suggested to perform a Schirmer test. And that turned out to be less than 10 millimeter, and it turned out to be positive. And guided by the positive Schirmer test, a biopsy of the salivary gland, so a real tissue biopsy, has been done. And this showed chronic sialoadenitis, grade 4.1 in the Chisholm-Mason classification. And that's a classification that has been it's being used to diagnose Sjogren's disease. It is positive for Sjogren's disease, I think, when it is above 4. And the patient was then diagnosed with something fairly rare, a seronegative, and really a completely seronegative Sjogren's disease, which affected the lung and can, in its extremest form, and this is what I've seen in Germany while I was there on vacation, cause the patient to suffer shortness of breath to the point of suffocating or feeling that he or she is suffocating. That was, for me, the learning from this case was you can have Sjogren's disease even if all the serology is negative, and this makes it so incredibly difficult.
Wow, that is so interesting. And kudos that, that had been brought up in the chat on whether the serologies, right, could be negative, was still present. Was the lung pathology then, Hans, was it coded as like a lymphoid pneumonia because Sjogren's, right, does have interstitial lung disease, and it's lymphoid pneumonia, or it can have sort of a cystic component. So I'm wondering if that was sort of the final label for the lung disease.
I think that was a lymphoid pneumonia, because if we had taken a real biopsy, probably from, can we take it from the alveoli, from the tissue itself, we would have seen the same lymphocytes that are being shown in the salivary gland, and that should basically confirm the diagnosis as well.
Yeah. So fascinating. Really, really interesting. And just again, the take-home point I feel like we often getting in the cases is listen to the patient's symptoms, right? And there was still an unexplained symptom that when pursued sort of led us to the final diagnosis, even as we were sort of distracted by the pulmonary findings. So
Yeah.
really great case. Thank you, Hans. Any final reflections before we turn it over to Manaswini?
Amazing case, and as always, such a privilege to learn from these patients, you know, across the world. Made me think of a couple of patients recently I saw with rheumatoid arthritis and pulmonary symptoms, and I learned from those patients that you know, whereas most of the time you can get nodules and kind of interstitial lung disease, but actual sort of airway involvement and bronchiectasis is pretty common when you have autoimmune disease affecting the lungs as well. And I don't know if all of that, again, if that's sort of like direct immune-mediated injury to the airways, or if it has to do with some of the sort of dryness and kind of mucosal injury and healing through that process. But fascinating. Thank you, Hans. Thanks to everybody in the chat for all the communal learning. I loved it.
Manaswini, we'll turn it over to you.
Fascinating case and amazing discussion. I'd like to share the teaching points. So we started off by approaching the cough, whether it was dry or productive, and we saw there was scant sputum, which may be due to bronchospasm or reactive airway disease, maybe reflex mediated, or medications, or postnasal drip or abnormal bronchoria, all suggesting upper respiratory etiology. But there may be secretory or parenchymal process due to infections and malignancy may still be a possibility. And other non-pulmonary differentials we had in mind, which included cardiac, like pulmonary edema causing crackles, or thoracic disease irritating the pleura, microaspiration, and other neurological causes. It's important to note the time course here, which is chronic, which kept viral etiology and pyogenic lower in our differentials, and we thought more on the non-infectious lines. We also saw that crackles have a variable sensitivity seen in 100% cases of interstitial lung disease, and in fact even precedes radiological findings on the CT and on the X-ray, versus sarcoidosis, which may present with crackles much later. And upper respiratory symptoms here had an atypical time course, so it was important to keep in mind airway inflammation and allergic environmental exposures, and also if it was immune-mediated hypersensitivity conditions. And no systemic symptoms kept malignancy and infections, again, low on our differential. And we saw eye involvement, which might have been due to conjunctivitis, scleritis, or uveitis. Again, anterior versus posterior versus pan-uveitis may differentiate the pathology. And mucous surface of the eye is injured. It may and we saw xerosis, which was dryness in the eye, maybe due to vitamin A deficiency, or it could be infectious, again immune mediated, which might have needed artificial tears. And another important point we brought up was ACE inhibitors increases bradykinin, may cause the cough, but not the eye symptoms. And cough plus eye involvement may also be seen in whooping cough and subdural hematoma of the eye, but they do not cause eye inflammation, so we rule them out. And pulmonary ocular syndromes is what we considered, and which included granulomatous conditions like sarcoid, mycobacterial infections, ANCA vasculitis like GPA and EGPA, and polychondritis, Sjogren, and post-infectious mycoplasma syndrome, shared by Lucas on the chat. And a fun fact was also the Mickey Mouse sign that you showed, that radial veins on the either side of the radial artery. And it is important to note whether it was an ABG versus a VBG, and we saw respiratory alkalosis here due to the lung involvement. And it was important to note that negative tests never rule out immunological conditions, and Sjogren is 30 to 40% of the times negative for SSA and SSB. And those were my teaching points.
And it's funny, that was an amazing summary. Thank you so much. Thanks everybody for joining. Lara and Muhammad and Hans, thank you again, and hope everyone has a great day.
Thanks, everyone. See you next time. Bye.